I now declare
over the numbers.
So sorry, we could have provided the breakdown by provinces. I don't have that with me. I don't believe. Robin, do we have it? Okay, so I will let Robin maybe to give you the detail for Manitoba and Ontario. One thing I will just add is when the audit team did their work, one thing that we had a deficiency on was to supply the evidence as well. So some of the number in terms of deficiency is due to our own lack of organization for that. So our numbers are a bit better.
I hate to interrupt you, but that doesn't speak well to your department if you can't supply your own evidence to support the systems that you're actually working with. The whole idea of being able to tell the Auditor General and then Parliament whether your system works is being having the evidence you can actually prove it. And so that's actually a deficiency of your department, sir. I don't think it's anyone else's deficiency. How much time do I have? Thank you. At page 5 of the Auditor General's report, Mr. Perron, at 4.26, he talks about the issues of nurses not having completed mandatory training, goes back to a previous report of 2010. And also later in his report, a similar comment is made at page 23 of the English at 4.115. Similar idea, need to measure the Health Canada provides comparable access was also raised in 2010. The Auditor General said in both of those paragraphs, you were told in 2010 you need to do this. Now, I'm not suggesting, Mr. Perron, you might have been the person there, I don't know. But clearly your department was. And here we are, 5 years later, and you did supply at the time an action plan to this committee for the 2010 report that said thou shalt do, and some of the timelines are June 2011, April 2010, December 2010, March 2011. This is May 2015. If I was your teacher, you all flunked. Do you have any response to why this didn't get completed and the Auditor General is now back saying to you, how come? And you're before us, we're asking you, how come?
Thank you for your question. The main reason for being behind on the training is the recruitment and retention. We have a high turnover of nurses, and our first order of priorities was to make sure that we have nurses in the position to deliver the service on an ongoing basis. This is not a justification to not meeting our own mandatory training standards. I would agree. This is a problem we are trying to fix. And at the same time, as we are investing a lot of energy on training to improve our numbers there, we are also running a really aggressive recruitment strategy. And we are hopeful that we will be able to stabilize the workforce, because to be able to deliver that mandatory training that has to be repeated every year or every 2 years for some of the course, we need to have a stable workforce. Each time we lose a nurse, we need to start back, and the new nurse may come in an employment position without that nursing background or the mandatory training met. So this is a fundamental issue we have with the training, is the ability to stabilize the workforce. We still have a high turnover of nurses, but our recruitment strategy is starting to produce results right now. So this should help to stabilize the workforce and be able to help to improve our numbers in terms of training.
Very good. Thank you. Time has expired. Over to Vice Chair Carmichael. You have the floor, sir.
Thank you, Chair, and welcome to our witnesses today and to Auditor General Ferguson. Mr. Perron, I'd like to begin with you. Begin with a question following up on my colleague opposite's line of questioning. I want to talk about qualifications that nurses must have through their provincial certifications before they are employed in nursing stations. If we can start there, could you expand on that and talk to what does it take to, in terms of the qualifications that are going to produce somebody who is clearly capable of doing the job?
Do the introduction and let Robin Buckland add on this. To be employed by Health Canada, you need to be a registered nurse in one of the provinces where we are operating, and in the province where the service will be delivered. Sometimes we have nurses that are registered in more than one province, and then we can have them practicing in more than one provinces. Robin is probably better placed than me to tell you a bit more about the credential that these nurses need to have to be able to work at Health Canada.
Yeah, and perhaps, thanks, Sunny, maybe I can also clarify that I am a registered nurse, and I have been for the last 27 years. To become a registered nurse, you have to complete a nursing program. So in the vast majority of the country, it's at the baccalaureate level, so you have to have a degree in nursing. In Quebec, the entry to practice is actually a diploma, so you can obtain a nursing diploma from the Cégep in Quebec. So basically, through nursing school, you obtain sort of the core competencies that are required to function as a registered nurse. Generally speaking, nurses come out of nursing school and they are generalists. They're able to do practice in a wide variety of areas. In remote and isolated locations, there are additional competencies that are required. As the report indicated, they are often the only provider in the community, and they are the first point of contact for the patient. So they need to be able to respond to what comes in the door. So if it's an emergency, if it's a trauma, they need to have the competencies to be able to deal with it, which is why Health Canada has identified the advanced cardiac life support, the pediatric life support, the trauma, and the other courses that you see listed as our 5 courses, because those are the key competencies that the RNs will require to meet the needs of the community, in addition to so much more.
So, if I can continue with you, Robin, as you explain it, and again, I'm from outside the medical profession, a long way outside it. As I hear you, you talk about the core competencies. When they move into First Nations and isolated communities as the sole provider of health care in that area, are the types of qualifications that they're required to have when they come into the practice, is that fairly common across the country, or is this just the entry level and then we've got to increase the standard from there?
So that is our expectation, is that they have those competencies. That's where it begins. It's not where it ends. In addition to those, I would say more highly technical skills, there are also a lot of additional skills that are required, including cultural competencies to be able to offer safe healthcare services. They are often the only provider and the first point of contact, but we do work toward having a team within the nursing stations. So nurses have access to nurse practitioners, nurses have access to physicians, either in person or via telephone or e-health. So we do like to make sure that they have access to an interprofessional team. I'm going to stop. I'm not sure that I fully answered your question.
Well, it's my time. So as you explain it, it's clear, and from the report, each of these individuals is very, very integral to the community and very important to the care of that community. So you talk about turnover. You lose one nurse, one key individual, and you've got a major gap. So could you talk a bit about the recruitment process and how do you deal with the loss? If you talk about a team, how many teams are out there, and how many locations are there with just a single practitioner?
We have very few nursing stations with less than 2 nurses within them. Generally speaking, we like to make sure at least there's a team of 2. We have 53 nursing stations that we deliver nursing services in ourselves, as Sunny indicated, in Alberta, Manitoba, Ontario, and Quebec. Sorry, and I forgot the second part of your question. I apologize.
Recruitment, briefly.
Recruitment.
Because obviously that's integral. Very briefly.
Go ahead, please.
Okay, we're working hard. And I think this responds to, in part, your colleague's question about how have we come this far and not got our training done. Our turnover rates are very high. We recruit 10 nurses and we lose 5. So it's very difficult. And when you have a nurse going out of the community to obtain their training, we work hard to get a replacement into the community so that the community is not missing access to services. So we do that in a number of different ways to make sure that service is continued.
Very good. Thank you. Time's expired. Over now to Monsieur Jaguar. You have the floor, Monsieur.
Monsieur le Président.
Thank you, Mr. Chairman. My question is for Mr. Ferguson. It's a more general question. This is not the first report you have presented on First Nations issues, and unfortunately, we've seen time after time that all of these reports indicate that First Nations don't have all the services they should expect. So when you look at promises which have been made in the past, well, these promises have rarely or sometimes or not always been fulfilled. Is there a service criteria for Canadians and another one for First Nations? Because given the number of reports tabled over the last years indicating that First Nations always receive lesser service, my question to the public service is this: are there two standards? How do you explain the fact that we are seeing yet another report indicating that First Nations are not receiving the services to which they are entitled? I believe that generally speaking, the situation we're referring to here is similar to other situations that we have highlighted in other reports on First Nations.
The departments having said that there are certain standards that they have to meet, that they have to live up to, but not doing that. So again, in this case, it was a situation of nurses supposed to have the training and not getting the training. Again, it was mentioned earlier that some of these problems have been known for a while, but they have not been fixed. Over the last few years, we've done audits on policing services on First Nations and also on emergency response on First Nations. And I would say that the types of problems that we are identifying here are similar to the problems we've identified in those other audits. You know, we haven't done anything to look at it from the global perspective to try to understand, you know, why are those problems persistent. Certainly we're dealing with First Nations that are remote. But nevertheless, I don't think that excuses the fact that departments are not living up to their own set of standards, the expectations they've set for themselves for the services to provide on the First Nations.
Monsieur Ferguson, au point...
Mr. Ferguson, at point 4.4, you talk about social determinants, which are an essential element. These social determinants affect the health of First Nations. You talk about overcrowding in housing, unemployment, lack of access to drinking water, and so on and so forth. As a result, today, First Nations have a survival rate or life expectancy much lower than that of other Canadians. Statistics Canada's figures have shown that it is quite an important discrepancy, and given the growth in the population of First Nations, well, these problems are just growing worse instead of us finding a solution to them. You've talked about coordinating the actions of various stakeholders. Prevention and public health are important factors when it comes to people's good health. Therefore, is the department making an effort to address these issues which make the health of First Nations worse, such as the lack of access to unsafe drinking water, overcrowded housing, bad follow-up for when it comes to psychological care, which has led to a high suicide rate? Is any real effort being made to address these issues? As well, we know that other issues are at play as well.
Downplay the issues certainly that were found here. I mean, I think when you look at our conclusion, we have said that the department does not have reasonable assurance that these First Nations had access to the services and the medical transportation benefits that we examined. So again, I don't want to downplay sort of the complexity of the environment that the nurses are operating in and the challenges that they face, including these types of social determinant challenges. But fundamentally, in the course of this audit, we found that there were a number of things that the department could have been doing better, that were within their power to do better. So despite the complexity of the situation and those problems that they face, there's more that they could do. Now, the department has agreed with our recommendations. They've said that they're going to implement our recommendations, and we feel, in this audit we made 11 recommendations, which is more than we make in a lot of audits. And we certainly feel that if they can put measures in place to deal with those issues that we found, to deal with the recommendations we made, we certainly feel that it's possible for them to significantly improve the services to these remote First Nations.
No,
C'est tout.
thank you.
Merci. Over to Mr. Hayes. You have the floor, sir.
Thanks, Mr. Chair. To Mr. Perrin, I'm looking at page 18 of the Auditor General's report, Exhibit 4.3, and that's a chart. And there's something I don't understand on the chart. In terms of non-medical escorts, i.e. pre-authorization of non-medical escorts, in all circumstances, that occurred. So in Manitoba, 18 of 18, and Ontario, 14 of 14. And I'm confused as to how there could be a pre-authorization of non-medical escort without even knowing that medical transportation was required. I want to understand a little bit about that pre-authorization.
So the non-insured health benefit program is a quasi-insurance program. So it confirmed that coverage will be provided and payment will be provided to the provider, whether it's the airline, the bus, the hotel, or the restaurant for the meal for the client. So every time someone needs to leave a remote insulated community, they will go to their nursing station. The nursing station will contact Health Canada regional office to say, okay, this patient needs to travel, go to this place for an appointment with a physician, let's say, or go to the hospital for x-ray, and then our officer will verify that the client is registered, that this is eligible under the framework, and will confirm that to all the providers that will need to assist the client to get to the appointment, we will pay and cover the fee of the services.
Particular case of these people, all 50 requests, we can assume then that all of the individuals were registered in Aboriginal Affairs and Northern Development Canada's Indian registration system, as well as Health Canada's status verification system?
It's the same database. They are connected together, so we are using the Indian registration system from ANSI as our source of information.
With respect to registration, does anybody get turned down if they're in dire medical situation and they need transportation and they're not registered? Do they get that transportation?
No. Especially in these remote and isolated community, when someone needs to be evacuated in an emergency situation, we do not get into the way of health services with administrative consideration. The person is medevac or is will get an ambulance service and get to the point of services. It's only after the fact that we will confirm that the person is registered, and if it happens that is someone that is not registered, then we'll have to send the bill for the ambulance service to someone else. But it's not coming in the way of accessing to emergency transportation.
And why isn't registration mandatory?
This is an individual choice. If people want to register and become an Indian under the Indian Act, they need to make the decision. Usually it's the parent, when the newborn comes, that will make the decision to fill the paperwork, provide all the piece of evidence, and get registered with Indian Affairs. But when you're registered once as a First Nation person, you cannot deregister. So it's an important decision, and we understand that there is various factors that influence the decision of someone to register or not.
You talked in your opening statements about, I think it was $300 million that was equated for transportation services. What portion of that is for medevac access? And can you talk a little bit about the medevac access program that's in place for remote reserves?
So in all regions of the country, we are trying to work as close as possible to the provincial health system or the territorial health system to make sure that clients, whether they are First Nation or Inuit, will benefit from the same access to emergency transportation wherever they live. In some provinces, there is a model where everybody residing in the province will be covered by the province and will only pay the co-payment for them. In some other province, they exclude de facto First Nation or Inuit, so we will assume 100% of the bill. There is protocol in place to avoid that they have to call us before. So the evacuation goes first. It's only an administrative procedure to decide who is going to pay the invoice for emergency transportation. But we have really solid arrangement in some provinces where I would say it's seamless. In some others, we are working to make it even more seamless, where wherever possible, when we can have a protocol with the regional health authority or the provincial health system, we will let them make the call about the transportation, and we'll be only there after the fact to deal with the administrative side and financial side so people get the services.
15 seconds.
That's fine. Thanks, Chair.
Appreciate the consideration. Thank you, Mr. Hayes. Moving over, I see we have Mr. Casey with us, not a regular member, but sitting in today. Welcome, sir, and you now have the floor.
Thank you, Mr. Chair. Anything but regular, I can assure you. Mr. Ferguson, you found in your report that we had nurses working outside their scope of practice. You found some pretty profound shortcomings in their compliance with a mandatory training program. My background before coming here was in defending lawsuits, many of them involving medical malpractice. And when I read your conclusions, it looks to me like a field day for the plaintiff's bar. So I don't know if my question is for you, Mr. Ferguson. It may be best for Mr. Perrin. In view of the shortcomings identified with respect to the compliance with mandatory training and the instance of working outside the scope of practice, has the department or its employees been sued as a result of what's been identified by the Auditor General?
No. And when there is incident, we are reviewing the incident in collaboration with the regulatory authorities or the coroner to make sure that we learn from these situations. But no.
The nurses in your employ would be obligated to carry liability insurance, I presume. Correct me if I'm wrong. And if that is the case, that they are obliged to carry professional liability insurance, has their insurance rating been affected by the shortcomings identified in this report prior to the publication of the report?
Again, the answer on this one is, as far as I can tell, no. I'm not aware of that. Robin, do you have anything to add on this question?
So the question, I believe, was, do they carry mandatory insurance?
Yes, and has it been rated up because of the shortcomings identified?
So nurses are obliged to carry coverage, as
yes.
you would know. And the federal government does provide that coverage for all of the nurses who work for us in First Nation Inuit Health Branch. That's the same for nurses working elsewhere within the federal government as well. And I'm not aware of any increase because of any situation. So.
Okay, so their professional liability rates have not increased based on experience in recent years, is that right?
That's correct.
Thank you. We saw recently where the RCMP ran afoul of the occupational health and safety regulations in New Brunswick because of how ill-equipped their members were. And when we see in the report things like septic system, which is not available for prevented the availability of nurses for 2 years, faulty seals on an X-ray room door. Same question, has the department been investigated by provincial occupation health and safety officers as a result of these violations?
No.
Certainly in the last 4 years, the government has been extremely preoccupied with balancing the books. They've gone through the deficit reduction action plan. There have been deep cuts in the civil service. Has your department been immune? And if not, how have they impacted the types of things that have been identified in the report?
There has not been any reduction to the clinical care programming. or the non-entry health benefit medical transportation, which were the two elements in scope for this audit. In fact, we have had reinvestment in 2012-13 into clinical care because the costs were getting higher, mainly due to the fact that we had a high turnover, a high dependency on agency nurses. We are still using a lot of agency nurses to compensate for the fact that we have vacancies in the branch for these services. So no, there has been instead of a reduction, there has been additional investment to make the cost of these increased costs. And we are really hopeful, if I can add on this, that our investment in retention and recruitment will allow us to use some of these resources that currently goes to agencies to improve services in the communities as well. So because it's a very costly model to rely on agency nurses to complement our staffing in the nursing station. So this is something that we are really hopeful that we can do better with the money, because I know the Public Account Committee is pretty concerned about efficiencies as well. There is a potential there to change the model of business, to reinvest the resources that currently we spend on agency nurses in the clinical care program, in enhancing our services.
Very good. Thank you. Time has expired. Moving along over to Mr. Aspen. And you, sir, now have the floor.
Thank you, Chair, and welcome, Auditor General Ferguson and officials of the Health Department. Just an overview question to begin with. What are the engagement processes at the national and the provincial level with First Nations and provinces?
Thank you very much. This is an important question because we believe that the best way to improve health services, not only clinical care, but all health services through integration of health services and creating more First Nation control over these services. I think one of the honourable member mentioned the model in British Columbia, and this is probably the furthest advanced transformation that we have under work. Since 2013, we have transferred all our operation that is now fully under the control of First Nation Health Authority, with an important participation of the provincial government in there. So this is the best way to integrate the services, to maximize the impact of the investment and get rid of some of the challenge we have with jurisdiction on who is doing what and why. I think when you get to this kind of model that we have in BC, these kind of questions are not important anymore. What matters is the continuum of service and continuum of care in the community. In all provinces, we have a co-management table with First Nation, and in most provinces, we have trilateral tables to deal with service integration. Unfortunately, I would say in the last few years, the focus has not been much on clinical care. One of the most important priority for our First Nation partner, and often from the provinces as well, have been on the mental health side. But we have made great progress there. I will maybe ask my colleague Valerie Gideon to give you a sense of where we are at with the main initiative in various regions in terms of trial tables.
Well, just very quickly, so we have a trilateral table in Ontario, the Ontario Ministry of Health and Long-Term Care, and we also have a specific northern table that the Northern First Nations has asked for. And in that table, which has just started this year, we do anticipate that we're going to be talking quite a bit about clinical and client care and medical transportation and engaging them in terms of our follow-up actions on that plan. In Manitoba, we've had a committee for several years that was at a more junior officials level. We've now bumped it up at an assistant deputy minister level with the province of Manitoba, myself, and the Grand Chief of the Assembly of Manitoba Chiefs. And as well, we will be using that table to engage First Nations in Manitoba with respect to our actions on this report, to ensure that we're also monitoring progress in partnership with First Nations. Those are just two examples that are more relevant to this audit, but there are many more across the country. We also have national partnership agreements with the Assembly of First Nations and Inuit Tapiriit Kanatami that we signed this year.
Thank you on that one. And what is the benefit of accreditation in improving health services in First Nations communities? And in your view, what progress have you made in that direction?
Thank you for the question. The accreditation is something that is being used in provincial health system and territorial health system to ensure quality of service in a health institution. We were talking about comparability before. Applying the same standards in the nursing station in remote and isolated community is a way to go to make sure that service is similar to in terms of quality. Maybe Robin, you want to add in terms of where we are at with our accreditation process?
Yeah, we're working hard to increase the uptake of accreditation in health services delivered to First Nation communities. As of 2014, we actually have, this is outside of the nursing station, but we actually have 87 health communities, health centers that have been accredited, and 43 treatment centers that have been accredited as well. Accreditation is really about a continuing improvement process and working with a set of standards that the health service or the nursing station can compare itself against, and then constantly work to improve the quality of the care that they are delivering. Again, a big focus for us since 2013 has been building capacity in First Nation community members delivering health services themselves. Where we're going in the next component of our strategy is actually looking at what we can do to increase the uptake of nursing stations, both Health Canada delivered and First Nation run for the accreditation process. In Canada, we actually only have one nursing station that is accredited, and it's run by Aboriginal community members in Quebec. So we've got a lot of work to do, but there's a lot of promise, and there's been a commitment to increase that number to 18 between now and 2018.
Thank you. Time has expired, Mr. Aspen. Thank you. Over now, the floor returns to Mr. Allen.
Thank you, Mr. Ferguson. Your spring report of Chapter 4, I noticed, has 11 recommendations. I've been here for a number of years. I don't remember the last report that had 11 recommendations in it. Maybe it was the F-35, and even that one I don't think had 11 recommendations in it. Is that on the high side for recommendations from your department, or is that sort of, would that be, it's not an average in my experience, but I wonder if it's an average in the department's experience.
I think certainly in recent practice having 11 recommendations is on the high side. I think in the course of this audit, the type of things that we were noticing were at specific levels, so it was it lended itself to being able to make recommendations at each of the things that we looked at, but I think overall 11 recommendations is on the high side for one of our audits.
Mr. Perron, I think actually, I don't think you actually said this, but I think Ms. Buckland, you actually gave me the number. We talked about retention. I think you said on average you recruit 10, lose 5. Was that right?
That's correct.
I can imagine you do. I have no idea what you pay them, and I don't want to know. But when I look at the Auditor General's report and he talks about supporting mechanisms that actually support the scope, working outside the scope, I'll be personal. My wife's a nurse. She's licensed in the province of Ontario. Working outside of her scope, loses her license if she gets caught. So I can imagine nurses get nervous when they're asked to work outside of their scope, not necessarily by the department, but by a patient who's there in a remote region that can't get service, and looking at someone who's critically ill or injured and doing what they need to do to serve the patient at the time is outside their scope. What a dilemma, Ms. Buckland, they're placed in, and you're a registered nurse with a license. You know exactly what that means to them. So I can imagine the stress they go through that. And then we hear about a residence that for 2 years doesn't have a septic system. I live in the country. I had 3 kids who used to live in my house. I can imagine that septic system being down 2 days and there being a riot. Never mind 2 years. Can you imagine living in those conditions, Mr. Perron? Do you wonder why you have retention issues? Working outside the scope as a professional can lose your license. You're asking them to do that. You're placing them in a position to have to do that. Having them reside in a place that basically isn't fit for human health. And then you go, the Auditor General goes through a litany of other things, ventilation and cooling systems that don't work. Working in an environment where the x-ray door may not seal properly and you're asking them to give x-rays to people. And you wonder why you have retention issues? I'm lucky you have any. It's amazing you don't have 9 out of 10 leave, never mind a 5 out of 10. Who would work in this kind of condition? You would have strikes across southern Ontario and every major manufacturer if this is how we treated our employees. And these sort of things weren't addressed. That's why you have retention issues. It isn't about how much you pay. It's about asking them to work out the scope of their professional ability to do so, that their license could be revoked. You place them in a place where it's unfit to live. You don't train them properly before they actually go. And then you say, we have a retention issue. Yes, you have a retention issue. You have major problems. You have 11 recommendations, of which 2 go back to 2010, 5 years ago, that you didn't get completed, that you promised to complete. And you said then you had a retention issue. You still have a retention issue. Quite frankly, your department, sir, has failed. You failed this Parliament because your obligation is to us, but more importantly, you failed First Nations people. That's who you really failed. This wouldn't happen in Welland, let me tell you. Never would we put up with this service in Welland. Wouldn't happen. There'd be a riot on the street if we thought this was the kind of service we were going to get. Nurses would not go to work in the places that you're asking them to go to work in if it was Southern Ontario. Wouldn't happen. That's why you have retention issues. You've got a lot of work to do, sir. And you need to start soon. In fact, you need to start 5 years ago, and you didn't get started then. So quite frankly, I have no idea how you're going to make this up and how quickly you're going to make it up, but you need to make it up in a hurry. I don't know what the resources you need, whether it be people, whether it be money, but if you intend to have a service that's equivalent or reasonably equivalent to what our expectations are, including your department's expectations, because you put them in writing, then I don't know when you need to get started, but by goodness, you need to get started a long time ago. The people of this country, our First Nations people, deserve better, and we've failed. Hopefully, sir, when the next report comes from the Auditor General, we won't be seeing the same thing. Because quite frankly, to be truthful, in any other major industry or other place, heads would roll. My friend across the way and I worked in the auto sector. If this was an indictment of our sector, heads would roll for that kind of performance.
Thank you, Mr. Allen. Thank you. Moving along to Mr. Falk. You have the floor, sir.
Thank you, Mr. Chairman. Just furthering a little bit more on Mr. Allen's comments there, you did talk a lot about, your department has talked a lot about, the Auditor General has talked a lot about the whole issue of employee retention. Is that something that you as a department have addressed? And you know what, maybe just to help you with the direction where I want to go, when people leave the employment of a department, do you conduct exit interviews? And when you do that, what is the primary reason for people leaving employment with the department?
Thank you. As part of the recruitment and retention strategy, one thing we are trying to do more and more is to inform the nurses about the work condition and the type of work that they will be asked to do in the communities, to make sure that when we invest into training and integrating these people into the health team, they will stay in the business and there will not be surprise up there. So we are spending a fair bit of energy up front to describe the situation. These are location really small team. They are not part of a large team where they will have connection. There is infrastructure challenges in the community in terms of access. So these conditions needs to be well known, and this is an important component of the strategy. There has been an important reaction from our marketing campaign. A lot of people came toward us to ask for information about these programs, these services, how this is going to work up there. And we are really confident that we will be able to attract a new group of workers. But among this, what we are trying to do to address one of the issues of scope of practice is also to integrate nurse practitioners as part of the team, because one of the issues with scope of practice is that our model was relying a lot on registered nurses. Nurse practitioners have the ability to perform a larger span of duties and to support nurse practitioners, registered nurse, to do more work as well, addressing a portion of the issue with scope of practice. So I'm happy to say that, for example, in Ontario, we're trying to recruit 10 more nurse practitioners to place them into a northern and a remote isolated community in Ontario that will address that. It's going also to reinforce the team and creating a cement for people to want to stay in the community and these health team because they will be better supported. In all nursing station, whether it's Ontario or Manitoba and in the other province, there is arrangement in place with physician services. So while nurses are there and somehow isolated physically and in really small team, they always have access to a physician or a nurse practitioner for consultation, helping with the scope of practice. So we are trying to clarify these rules so people are less afraid to come to work at Health Canada and understand that they are not left alone in this field while the work is pretty challenging and demanding. Maybe, Robin, do you want to add a little bit on the recruitment strategy where we are at this time?
Yeah, and I guess I want to start by underlining that scope of practice is a big issue in terms of recruitment and retention, and it is really important that we have a safe practice environment for our nurses to work in. Or, as you indicated, nurses will not want to come to work for us if they think they're going to lose their license. But as Sunny had indicated, the vast majority of situations nurses find themselves in, they are working within their scope of practice, and we do have these other supports where they're able to call the doctor and get that order. So what they've done is not outside their scope. So that's really important in terms of recruitment and retention, having that safe practice environment. We're increasing the visibility of this as a place to work, and despite what the report says, there are nurses who are excited about the idea of coming and working in First Nation communities. It provides an opportunity to do stuff that they wouldn't necessarily see in downtown Toronto. It provides them an opportunity to work in another environment, learn another culture. There are really some really exciting things about working in First Nation communities. We also, in addition to our mandatory training, we're working in terms of recruitment on a development program that's helping in a couple of areas. Number one, training nurses in charge, because you've got to have that leadership if you're going to have a good practice environment for nurses in which the processes are followed and everything runs smoothly. So that's one part of the development program. The other part of the development program is bringing in those new grads, and as Sunny had indicated, making sure it's the right kind of person that we're recruiting, and then training them up and making sure that they have got what it takes to work in this kind of environment, because it does take a special person. As well, student outreach, connecting with new grads, going to universities and encouraging them to apply, and then working at optimizing our staffing mix is another part of our recruitment strategy, making sure we've got doctors, nurses, nurse practitioners, paramedics, so that we don't run into the scope of practice issues.
Follow up, I'll allow it really short.
Yeah, I've got some good news for you. This last week in Manitoba, 60 new oral health professionals graduated from the university, 35 of them dentists, 25 dental hygienists. The majority of those come from the province of Manitoba. They were born and raised there. There's an opportunity for you there. Can you talk a little bit about your new oral health initiative that's happening among the First Nations people?
Very, very briefly, please.
Yeah. We have an oral health initiative that focuses on 0 to 7 years old, mainly focusing on prevention to avoid decay, dealing with early problem, putting sealant on teeth to prevent further problem in the future, changing the behavior. We rely heavily on dental therapists, dental hygienists to practice in the community. We are bringing them for visit in the communities. I was in Northern Ontario last week or 2 weeks ago, and there was one of the dental hygienists that was there with kids in the clinic doing treatment. So this is a very aggressive strategy that has been in place for a number of years, where we are bringing the health professional, the dental professional in the communities. I'm really pleased to hear that there is more graduates that can practice in the community going forward.
Very good. Thank you, Mr. Prawn. I appreciate you keeping it as brief as possible. Okay. You're back up to bat, Mr. Basie. Mr. Casey? Basie. See, it was a good line when I thought of it in my head. I know. Well, that's what it was supposed to be, and then I blew it. So you have the floor, Mr. Casey. Thank you,
Mr. Chair. Mr. Perrin, Mr. Allen took quite a rip at you and your department and didn't give you a chance to respond. He told you in no uncertain terms what he thinks is the reason that you have a problem with turnover and retention. This is your chance to respond. Do you agree with his critique, or is there some other reason that you can put your finger on that retention is such a challenge for you?
I would say I agree with some of his point, obviously, that the work in the communities is challenging. It's not an easy task. The isolation factor, as I mentioned before, the small teams and the lack of connection is a challenge. The infrastructure is a challenge as well, because we are really far to go there and fix problem. I think the Auditor General audit point out to the fact that some of the repair were needed and not done on time. The example of the Deer Lake residence that you mentioned, this was fortunately not the nurses' residence. It's one of the residences that was, but it's not the one used by the nurses. There was other residence for them, but having good residence for the nurses, it's an important factor of retention. We have invested in the last few years in the maintenance and construction of residents. Those factors are all in there, but the problems and the issue appear to be a bit different in the different locations. But I would say what have made a huge difference over the time is the ability to create a team that is well integrated in the community. One of the recommendations is about integration of clinical care into the health planning of the community. We have in many communities where Health Canada delivered the clinical care services, still a situation where we deliver services and the community runs everything else in terms of health programs. And there is a need to really having a good integration, because the nurses are essential to the delivery of some of the community health programs. And the community health worker can be a great support also to the nurses to deliver what they are doing and dealing with what they see in their day-to-day consultation with clients. So this element of integration and making sure that the nurses' work fits well with the community health plan is an important element going forward that we have tried to invest in there. We have to do it again. There is a divide there in terms of what we are doing and what the community is doing, but there is attention being put on that. I think improving the infrastructure is also on the electronic side. Electronic medical records and telehealth. We have made a lot of progress in various provinces and regions to deploy telehealth in the communities, so then a patient can consult with the nurse, a physician over telehealth, or they can access mental health workers through telehealth. So this is an important element of our strategy to improve the quality of the service and the connection between the nursing team in the community and health professional elsewhere. Implementing electronic medical record, essential. I was talking to a physician that practiced in one of the nursing stations, and what they want is when they visit for a week or so one in the nursing station working with the nurses, the ability to continue their practice on electronic medical record that is part of the provincial system, to be able to advance their work and make sure that clients' next step in terms of treatment will be in a system that they know when they practice in the South. So we have to invest more, and we are into the enabling infrastructure, not only the physical infrastructure, but also the IT infrastructure. And this is one place where the nurses for years have complained about connectivity. In Northern Ontario, we have 5 communities where the high-speed, large bandwidth is not yet available. We are getting there, working with partners, so these communities will be well connected going forward. It's building this infrastructure also that allow a small team into an isolated community to be able to be connected with the rest of the health system and transfer file, do referral, receive results of exams and tests electronically. So this has been more and more visible in the community in the last, I would say, 5 to 10 years. We still have issues to deal with to build that in some of the remote northern communities in Ontario and Manitoba, but we are getting there. So by building the enabling infrastructure, I think we'll also have a better chance to retain nurses that can compare, because sometimes they work part-time for us and part-time elsewhere, and they will say, oh God, you're missing some things here that if we had that, this will work way better. They do not dream about having a road access. There won't be a road access there in the near future in the community, but they dream about having access to the information that allow them to practice with their full capacity there. Adding nurse practitioner in the team is also a way to reinforce the nursing team, so they don't feel that they are isolated, because they can get guidance for a nurse practitioner in terms of doing some of these action that otherwise they would not be able to do, or they would not be able to do without breaching their scope of practice.
Sorry, but like 2 seconds, so enough time for me to say thank you. Moving over now to Mr. Woodworth. You have the floor, sir.
Thank you very much, Mr. Chair. Thank you to the witnesses. There are 2 areas I'd like to ask about, and I'll at least start by directing my questions to you, Monsieur Perron, and you can pass them on if it's appropriate to do so. You've already touched on both of the things that I'd like to ask you about, so I'm essentially just going to try and get a few more details. One of them has to do with recruitment, and I noticed in your opening remarks that there are at least 4 new tools or initiatives that have been mentioned. One is the Nurse Recruitment Marketing Plan, another is Nursing Development Program, third is Student Outreach Program, and fourth is the Onboarding Program. And I also know that you have to look after about 91,000 people, and I seem to recall seeing somewhere in the material that there may be something in the order of 400 locations, or at least many, many locations, and many of them in remote areas. And it's that remoteness that I'd like to ask about, because I think that that in itself creates a challenge for recruitment, apart from everything else that we've heard here today. And I can think of a number of different ways that one can try to attract people to remote areas, but I'd like to hear what, if anything, you're doing to try to make it easier to attract people to more remote, isolated areas.
Thank you. I would say one of the things we have done for almost 15 years now is invest into health human resources to not only attract people from the South working in the First Nation community, but also to increase the number of Aboriginal health workers. And this has been an important investment for the branch. While most of them may not come to work in First Nation and Inuit Health Branch at the end, they may decide to go to work for the provinces or work for the First Nation community themselves, which is great. Having more health workers that have an Aboriginal background is one element of the strategy, because we do have in our employees people that are coming from First Nation community, working in First Nation community, and we are really proud of that, because the cultural dimension of the health service is very important. Something that you're probably all aware is that we have a lot of people that when they come in the South to visit an hospital or see a physician, they are a bit nervous about that contact because they are not used to. So the cultural appropriateness of the service, we are trying to bring that also in the community, thinking that this will also create a more resilient and more stable workforce there. So very important investing in there. I think informing better the nurses. You may, if you have not, I will invite all of you to go on the Health Canada website to see the video and the information we have displayed there since February this year in terms of what it is to be a nurse in First Nation community, to try to attract more workers in Health Canada, but also using that as a way to, if people prefer to work for First Nation community, we'll direct them there. So an aggressive marketing campaign to show what it is to work there, because there is also advantage for people that like to live closer to nature, that like to work in small teams, that want to face challenges. So there is value. So we are trying also to amplify the positive side of this. There is not only negative. I think working in this environment might also bring a lot of satisfaction for the health worker. In fact, we see that when we meet with our staff that are in these locations, they are very dedicated people, highly professional, highly conscientious, and they like their work. Some will go there for a while because the bad side of that, and we are trying to be very, very transparent on that, is that there is a lot of overtime. For people working in these communities, if there is someone that is sick at night and the nursing station is not open, they will go there and they will be on overtime. So it's usually sometimes really long shift, really intense time in the community. So some people are attracted by that. We are trying to profile this as well. I don't know, Robin, if you want to add something about the onboarding or the training and retention, the training action we do to prepare nurses to go to work in the communities.
Yeah, I think, if I may, the onboarding is going to be quite important, and making sure that we are recruiting the right kind of person and preparing them for the type of nursing that is going to, but that they're going to be facing. So I think that that's really quite important. Yeah.
I just ask about a few other issues. I don't know what the pay and benefit structure allows. If you hire someone from the South, do you assist them at all by giving them some form of occasional leave to go back? And if so, transportation assistance? And do you provide a residence for all your nurses or give some kind of housing allowance? Can you tell me a little bit about those incentives, if you have?
There is an housing arrangements in most community. Health Canada is built with the First Nation nursing residence nearby the nursing station, and those are considered facilities that we support. They are owned by First Nation, but we invest in there, and nurses have access to these residents. They will receive isolated post allowance as well in addition to their pay. They will receive a retention bonus or amount in addition to their pay to attract people and retain them in the north. They will be eligible to overtime and callback measures that are all planned in the collective agreement that are highly used in these kind of settings. Robin was talking about like a 2-3 nursing station. It means that that team might be on very long shifts. So we are trying to profile that. The nurses going into nursing station do expect to do a certain level of overtime there because they will be posted there for a number of weeks and then go out. We have also a lot of nurses that do part-time that will want to do 2 months with us during a year. They go back to work elsewhere and they come back the year after for another 2 months or 2 weeks. So we have a lot of flexible arrangement to allow every nurses that want to practice in these community to work with us.
Thank you.
I want to switch gears.
No, sorry. We are going to switch gears, but it doesn't involve you, I'm afraid.
Thank you.
Sorry.
Thank you very much. And over back to Monsieur Giguère. Monsieur?
Merci, Monsieur.
Thank you, Mr. Chairman. Mr. Perron, on page 3 of your presentation, you talk about a compliance rate of 88% for prescribed medication. I did some medical law when I was in training. If a compliance rate was, a non-compliance rate was only 1%, people took action, but your rate is 24 times higher than what would be acceptable in a hospital. That is not good news. Can you explain to me how such a high non-compliance rate, 12%, of these medications can be distributed by your department? That is a huge number. It's between 24 and 36 times what would be acceptable in a hospital in Montreal or Toronto. We're not talking about non-compliant medication. We're talking about the number of nurses working for Health Canada, working at remote nursing stations, who have taken training on controlled medications. There is a renewal cycle of training, and perhaps Robin can confirm these numbers. Every 1 or 2 years, obviously we would prefer to have all nurses redo their training with regard to prescribing medication in nursing stations. We're not talking about pharmacies. The type of medication and the use of medication in nursing stations is very closely monitored, very controlled, based on a form. A form is filled out for every medication and for what use. And the training of nurses is made on that basis so that nurses can use all of the tools at their disposal in the nursing station. Well, the compliance rate for your service is 46%. 46%, well, you don't get a diploma if that's the mark you get. Even 65%, that is not something to boast about if that's the mark you get for a diploma. Yes, I agree with that, and we did say so in our presentation. The Auditor General, in his report, based on the sample taken in Manitoba and Ontario, had a 1% compliance rate using a small sample. But then we did more training, and now 46% of nurses working in nursing stations have completed all of the training out there, the 5 different training modules or points. Obviously, our goal is 100%. Training will be ongoing. New training is always brought in. We hire new people, and so they will get training. So the objective is to maximize the compliance rate for nursing staff so they get all the training they need. We want to make sure that when they work in their stations, they are up to par, and they will keep on taking training. Generally speaking, in the healthcare field, emphasis is put on prevention. I don't know if you've seen the documents of the Beijing's Cree Health and Social Sciences Council's report, and they talk about the food problems in Canada. I'm sorry, but people are dying. because they do not have access to clean drinking water, they do not have access to healthy foods, they are not getting mental health care. There are people who are dying. These people cannot wait 5 years. Can we really expect a change in mindset within the department? The status quo is unacceptable. We're not asking you to look away while people are dying. Nurses are an important component of healthcare services provided in remote areas. However, they are not the only components of services out there. We fund several programs. You mentioned nutrition. We fund a prenatal nutrition program. We fund nutritional education programs. We fund diabetes prevention programs and diabetes support programs. So nurses are the pivot, or rather are not necessarily the mainstay of these nursing stations. We also have community workers who work at the stations. The Auditor General in his report said that there are many actors who work upstream to educate people, to change behaviors. This is done on the ground in communities. I'm sorry, but what you are talking about, it all sounds very great. You're saying you want to fix the problem. But when it comes to outcomes, to these statistics, the fact is that the situation is getting worse. Things are not getting better. This is a huge problem. We can prove with numbers that some communities are in danger. They're being threatened. First Nations individuals are being threatened. So what is it going to take for this situation to, at the very least, improve? I'm not even talking about stabilizing the situation. What's it going to take for things to get better and not to regress? I agree with you that we need to take an overall or holistic approach when it comes to health care determinants. We're talking about changing lifestyles, supporting good eating habits and physical activity. There are other factors which are not necessarily covered by Health Canada's programs, which I cannot speak to, but they are also determinants of health.
May conclude.
So, may conclude?
Yes, you may conclude.
What I was, ce que j'ai ajouté, c'est qu'on...
What I would like to add is that we are working to ensure that these elements are all connected with our services. We want to work with communities. We want to work on other elements, quality drinking water, housing. It's very important to address those matters, because if we want to improve the health care of people, we don't only look at their health, but other health care determinants which do not fall under Health Canada's mandate. Thank you.
The floor, sir.
Mr. Chair, and again, look forward to the testimony here. I just want to go back to something my colleague had just referred to earlier. It seems interesting that he's talking about the importance of safe drinking water. I think we all understand that. We've passed the Safe Drinking Water Act that actually allows a First Nation to be able to choose if they want to have an equivalent one to a provincial, or if they want to fall under provincial laws, or if they want to follow the federal ones, they can do that. But that member's party voted against all of those changes. So sometimes it's a little shocking to me. Now, Mr. Allen also had raised some concerns, Mr. Perron, around the specific example that was given of a septic field that basically made it so a facility was not usable. You said earlier, sir, that many of these facilities are owned, operated, and maintained by individual First Nations, and that you have to do, I think what you said is we have to work on a longer scope to be able to make sure that your priorities also match with their priorities. Is that correct, sir?
And to support the process when there is a joint priority to support the process to make it happen.
It's interesting because the members opposite in the House say that we're being paternalistic all the time by putting forward, safe drinking water acts, etc. Yet when we actually say we need to work with individual First Nations and plan these things out, they get all upset that we aren't, suddenly marching in and fixing septic fields and stuff that are not even federal assets. They're, owned by the First Nation community. Now, I don't want to isolate one particular example because these things do happen on reserve, and they also happen, septic fields go bad in many other areas of, at least my province, where they're used in rural areas. I also know that many rural areas, in my province, the mayor of Karameas, the mayor of Merritt, the mayor of Logan Lake, when I speak to them, they're always working with their provincial members of the Legislative Assembly to try and deal with doctor shortages, and I'm sure the same goes with nursing shortages. So I can appreciate it. Specifically, when I hear that some provinces have made large raises and are attracting professionals from right across the country, it makes it very difficult for the provincial system to be able to operate. I'm sure with some of the examples Mr. Perron had given in regards to the isolation, but I'm also happy to hear. Now, can I just ask a quick question? Are we also trying to recruit from First Nations to take these positions? Because obviously they would have cultural understanding, they would be serving their communities, so they would be making very good money. Is that something that continues to happen as far as recruitment?
Absolutely. It's an important part of our strategy.
Okay. No, I'm very happy to hear that. Now, going back to codes and whatnot, we have the National Building Code is voluntary. Provinces then can adopt them, like, for example, British Columbia has its own building code, but a lot of people don't know that Penticton, the city of Penticton in my riding, has its own building code on top of that makes further revisions to the provincial building code. Can we just explain how building codes, how they work in the context or not work in the context of the Auditor General's report, Mr. Perron?
I will ask Valerie to maybe get on this one.
Sure, there's an easy one. So we've always required that, the actual buildings would be signed off by the professional engineers and architects that actually worked on the project. What we're doing now, though, in light of the report, is just make sure that it's explicitly written in our capital protocol agreement with the community so that, we'll get an actual report at the end that actually demonstrates, yes, that absolutely meets the building codes. But it was always part of our requirements. Now, we have buildings that predated the National Building Code requirements, so those, need to be sort of upgraded over time when we're building new nursing facilities, new nursing station facilities. We will, of course, now follow the code of that moment, right? So they will get updated over time. We have facilities that are 25, 35 years old, so part of it is also making sure that we're upgrading them, that we're renovating them in partnership with the community, so they can meet the standards.
Okay. Now, I know, Auditor General, I've criticized some of your recommendations for sometimes being a little wishy-washy or a little too general. But in cases where we have specific recommendations over a wide arch of issues, there's a spectrum of issues that are raised in this report. I think it's important that your office give very specific feedback. I don't see why having a quantity of recommendations actually somehow qualifies this report as being different. To me, I think your office is trying to be as helpful and instructive as possible in unique areas that you think that Health Canada could make a difference. Now, earlier, Auditor General, you referred to that's a very complex environment to work in. And so I would see that you're making these recommendations, 11 of them, with that in mind. Is that true?
I think, as I said earlier, the types of things that we found here lent themselves to specific recommendations on specific issues. So we would identify an issue, whether it be training, whether it be dealing with the scope of practice issue, whether it be the building code issue, that I think those issues lent themselves to very specific recommendations and very concrete recommendations that should also be easy to determine whether the department is able to put in place some measures to deal with those recommendations. So I think that was certainly an aspect for why there ended up being 11 recommendations in this audit.
Very good. Thank you. That concludes our usual rotation and therefore concludes our hearing. If I might, one quick non-partisan question in light of the fact that this is our last public hearing before the election, before election of a new parliament. Tomorrow's the Truth and Reconciliation Commission report. Mr. Auditor General, I've been on this committee 11 years now consecutively, and this one file in terms of services for remote communities, First Nations people, Inuit, has been a colossal failure across the board, and that's not partisan. I've been here under different governments, minority, majority, and your predecessor, the wonderful Sheila Fraser, one of her last comments as she left office was to raise this issue and talk about it as a remaining challenge for Canada in her view. I'm sort of putting you on the spot, but I wondered if you had any thoughts at all to give to the incoming Parliament, the 42nd Parliament, because from that Parliament will be chosen the next government, and they're going to have to deal with these files. And given the fact that we just as a country, because I believe most of the people on these files are people of goodwill, have tried to overcome these challenges and give our sisters and brothers in the remote north the quality of life that they deserve and that being a Canadian is supposed to guarantee. Can you give us any advice or thoughts to the next Parliament as we adjourn here on this, the main accountability committee of Parliament, for candidates and the next MPs to consider as they form government and move on this agenda? What we don't want is another decade of failure. Do you have any thoughts of words of wisdom to give to that incoming Parliament and how we can have different outcomes than we've been having?
I think perhaps a couple of things that I would like to mention. I think, first of all, I was very happy with the fact that the committee decided to have a hearing on this report. Since I've been in this position, we issued the audit also on policing services, the one on disaster assistance, and in neither case was there a hearing on those subjects. So I think the fact that we've had the chance to talk about these, the department's had a chance to explain the issues that they face, I think that has been important. I think, though, the other thing is to very much get an understanding of what the departments that are involved, and there are many departments involved in providing services to First Nations. So get an understanding of what those departments have said, that they, what they've committed to do in terms of providing services to First Nations, so that we get an understanding of whether they're living up to that. And also, I think the other thing we've talked about today is that many of the types of issues that we've talked about are issues that have been known for a while. They have come up in various other reports. And I think perhaps, for a future Parliament, perhaps it's important to go back and reflect on some of those studies and reviews that have been done on this file to determine where the departments are on them. So, I think that there's a lot that can be done to improve the situation. Obviously, it's a very complex problem, many departments involved, facing a lot of challenges. But I think, one thing that has been a common thread for me in these audits is that, it is possible, it is within the power of the departments to improve a lot of the services that they're providing to these types of First Nations.
Very good. Thank you very much, sir. We appreciate that. And colleagues, a reminder that we meet again on Wednesday to begin report writing. And with that, with thanks to our Auditor General, his staff, and the departmental staff, we now stand adjourned. Thank you.